We're very fortunate to have Dr. Julia Smith with us, who is an internationally recognized medical geneticist and oncologist. And Dr. Smith was extremely helpful in helping us put together the program. And we're very, very excited to have her here today. So let's just acknowledge Dr. Smith's background. She's a NYU alum all the way through, not only MD, but PhD in cell biology as well. And she also did her internal medicine at Harvard, and then oncology at Memorial Sloan Kettering. So as we say in the trade, it doesn't get much better than that. Yay! All right, terrific. And oh my goodness, and also did some postdoctoral work at Rockefeller University. So that's absolutely fantastic. And for all those reasons, she is clinical director of cancer screening at the Perlmutter Cancer Center here at NYU. And she also is director of the NYU and Bellevue Langone Foundation and Caring Together project for women at increased risk for cancer. So in our discussions getting ready for today's program, we provided Dr. Smith with the feedback we were getting from many survivors that in their interactions with their providers, people did not talk to them about genetic testing, either somatic testing of their tumors or germline testing to assess predisposition, including for Lynch syndrome, FAP, or MYH. So I'm going to stop right there, and I'm certain that Dr. Smith is going to give us a terrific review of the situation. Thanks so much for joining us. Thank you.
Good. Thank you. Well, it's very nice to be here. It's so nice that you all came out on a Sunday. It's great. And this is a wonderful program that you put on. I'm very happy to be here. So, what am I doing here? Basically, you know, I'm here to try, what I want to do is, I'm a medical oncologist. And for, as you heard from Dr. Weber, my research interests were molecular cancer genetics. But before the late 90s, what I was doing was taking care of patients with cancer. And that meant chemotherapy, sending them for radiation and surgery. And that was my job. Well, my research was looking at the molecular basis, the root causes of these cells going awry and causing this problem. So finally, in the mid-90s, the first cancer gene was cloned. That was the BRCA gene. That was Mary Claire King, a scientist who's alive today. She is still working hard. She said for years, she said, in some cases, there are families that are predisposed to cancer. There's a genetic basis to cancer in those families. No one believed her. The scientists didn't believe her. The medical community completely poo-pooed it. They said, you know, what are you talking about? You know, a gene for cancer? That's nonsense. That doesn't exist. She didn't give up. She went on to clone the BRCA gene in families who had demonstrated they had a clear hereditary predisposition to breast and or ovarian cancer. That made the field, it just busted the field wide open. She cloned those in the mid-90s, and that was it. We were off and running. So in the late 90s, we had those genes. We understood, everyone understood there was a genetic basis to cancer, and I believe a very fundamental genetic basis, whether we can find it at this time or not. And in the late 90s, we opened that clinic that Dr. Weber told you about. We had foundation money from Langone, and they helped us with support from Bellevue and NYU to open what turned out to actually be the first clinic in the United States, I didn't know that at the time, for underserved women to help them understand their risk of breast cancer. So from there, we worked to understand genetic basis of cancer, and the field grew. And in around 2001, NYU built a cancer center, a new cancer center, And then they came to us and asked us if we would open the cancer risk assessment program for the insured. It's actually the only program I know of to date that was first offered to the uninsured and then offered to the insured. But then we expanded from that point on to many other disease risk groups and many other cancers. And colorectal cancer was our next main interest. And it's turned out to be very important in terms of understanding genetics and in terms of preventing cancers. So that's my job. I'm here to get everybody to prevent that first cancer. That's called primary prevention. Prevent that first cancer before it happens. But if you get a cancer, you must prevent the subsequent cancers. And that is key. You know, in the 90s, we didn't worry about subsequent cancers, second cancers, third cancers. All we wanted to do as medical oncologists was get the patient through that first cancer diagnosis. And it wasn't easy, and many, many patients did not make it through that first diagnosis. But treatment, prognosis has changed. And now we expect to get many of our colorectal cancer patients through that first diagnosis. So if you are going to get them through that first cancer, the last thing you need is to have them brought down by a second, third, or fourth cancer that they didn't have to have if you had been able to recognize the predisposition, get in there and do something about it. So that is why it's important. This is, you know, this is what we know right now. We know that about 25% of all colorectal cancers are associated with a family history. Now that is growing. 10% are associated with well-recognized syndromes. And this data is changing as we speak because, you know, this was the problem with our understanding of genetics. And this is what I tell all the residents, fellows, students, everyone I lecture to now, and the doctors. Don't think anymore that you can rely on your own clinical judgment to pick out what syndrome a family has. The reason we thought we could, you know, in the 90s, someone would come in with this story of ovarian cancer and breast cancer, and we would say, oh, that must be a BRCA family. We'll send the BRCA. Along comes the Lynch, and we notice that patients who are negative with families with ovarian cancer for BRCA have a Lynch mutation. The reason we didn't know it before was because we weren't testing for it. We're developing more and more panels and extensive gene testing, and the more we develop, the more we understand what's called these crossover syndromes. So you cannot think as a clinician, as a doctor or a healthcare provider, that you can pick out what gene it is that a family has. You must test broadly because you will find new genes all the time presenting in different ways. So that's a list on the bottom of some of the well-described hereditary colorectal cancer associated genes. HNPCC is hereditary non-polyposis colorectal cancer. That's Lynch syndrome. FAP or APC are the familial polyposis. But we're now testing for other genes in addition to these that we know cause a predisposition, hereditary predisposition to colorectal cancer. The POL genes, the POLD1 genes, the GREM, we don't know how to act on those yet. We don't have guidelines, but we will quickly, much more quickly than we did with Lynch, because we're collecting the data much more rapidly. So these wide-ranging gene tests are extremely helpful, and they're providing us, you know, everybody knows that colorectal cancer is very common in our society, and everybody knows that you can't find a Lynch syndrome or a familial polyposis syndrome in every patient. So what are all those other colon cancers? We're starting to get a handle on what those are. Okay, so what can you do to understand whether you are at risk for a familial or hereditary colorectal cancer syndrome so that you can intervene and prevent the first, second, third, subsequent cancers? First of all, here, these are the contributing factors as an overview. I'm going to discuss some of them in detail, but family history and genetics is very important. It's something that you actually have to work at, because when you ask most people, and when you go into your primary care doctor or your family practitioner, and they usually ask you at the first, do you have a family history of cancer? Well, you know, if your mother had cancer, or your father had cancer, or your sister, or your brother, or your child, you usually think of that, and you mention it. But often it takes really just sitting and thinking and talking to your family, going back to them and explaining to them why it's important to think about this, to find out what the real family history is. And an extensive family history of cancer, understanding of where the cancers are in the family is extremely helpful. And I have very few patients, I can tell you, where the vast majority come in, we sit down, and I say, tell me everyone who had cancer in your family. And when they think of the first 2 or 3, and then I say, okay, if you think of any more while we're talking, let me know. By the end of our discussion, I have usually at least 5 people in the family, because it pops into their head. And if they know to focus on it, then you keep track of it. Personal medical history, I'm going to talk to you about this a little bit too, because it's not intuitive to patients what's important in their personal medical history. What's important, what seems important and may be important to you may not be as important in understanding the medical and genetic predisposition, and things that you might think are irrelevant may be very important. So we have to get an understanding, and I'll help you with that, of what kinds of things actually matter in reporting your history. Obviously your medical diseases and your personal history, and then lifestyle. This is, you can't do anything about your genes. You're born with them, and so far we can't change them, but you can change your lifestyle. And having a lifestyle and then changing your lifestyle is very important. In other words, you can do something about it if your lifestyle is not where you think it should be in terms of cancer risk and prevention. And colorectal cancer, we know that diet, exercise, and cigarettes and alcohol are important. Now, from my side, when I'm sitting, at the table and I'm talking to a patient, the things I'm looking for to try to understand whether a patient or their family appears to have a hereditary predisposition to cancer, any cancer, not just colorectal cancer, but if it's in their family, I'm looking to see, does that family pattern seem out of the ordinary for what sporadically we see in the United States? So, if somebody comes in and says, I'm worried that I have a genetic predisposition to cancer, and you say, why? And they say, well, my father got colon cancer at 77. Well, that's not good, and it may indicate something, but it is not a red flag for a predominant autosomal dominant gene that has a high penetrance that you will see expressed throughout that family. You're looking for something that just doesn't fit. If somebody comes in and says, I'm worried because my father died when he was 36 of colorectal cancer, that's unusual. That's something you have to pay attention to. So that's the kind of thing we're looking for, is what just doesn't fit the normal sporadic pattern. Also, unusual associated cancers. So I was talking about the BRCA. Everyone knows at this point, I hope, about the association with the BRCA gene and breast and ovarian. Not everybody understands that colorectal cancers have associated genes that have associated cancers as well. And that is true for many of the genes. So you might think that a particular cancer in the family, it's not colon cancer, so I don't have a risk of colon cancer. But in fact, there's a family member with a pancreatic cancer, a small bowel cancer, a biliary cancer, and that in fact is actually a tip-off that there is a gene and it can be linked to risk of colon cancer. And if you find it, you can get in there and prevent those cancers. So multiple primaries in the same individual, same kind of thing I'm talking about with that sporadic cancer pattern. It's not good, and it's bad luck to get a cancer. But if somebody gets two different cancers, not a recurrence of the first one, but a second primary cancer, they have had one cancer of the kidney, and then they get another cancer of the pancreas. That is not just bad luck. Something is going on in that person's surveillance system, which it may well be related to an underlying gene abnormality, gene misfunction, that's predisposing that person and that family to more than one cancer in the same individual. We'll talk about these family clusterings of cancer. And then we know multiple adenomas in the same family. So, you know, I hope that certainly most doctors, because even when I was in medical school, even then, we knew that if a gastroenterologist called you up and said, you know, this patient you sent me, I did the colonoscopy and the entire colon was carpeted with polyps. I couldn't even see any normal lining, mucosa it's called. That person has a genetic predisposition and will get cancer of the colon if you don't intervene. And then certain specific risk groups are at increased risk. So you have to think about those things. And this is just to illustrate that, you know, people need to pay attention if their family has a history of colorectal cancer, because the general average population risk is 1.8%. It doubles with one affected relative, and it starts shooting up significantly if there's more than one affected relative with colorectal cancer. So now I just want to talk a little bit about the types of colorectal cancer hereditary syndromes. We kind of separate them into two buckets: the non-polyposis colorectal cancer syndromes that are hereditary and the polyposis syndromes. So the HNPCC is Lynch syndrome, hereditary non-polyposis colorectal cancer. Those genes, there are 5 genes, 5 what are called mismatch repair genes that contribute to people developing these cancers. And anyone who has a mutation in any one of those 5 genes will have Lynch syndrome. So if you have that syndrome and a mutation in any of those 5 genes, your lifetime risk of developing colorectal cancer, these are my abbreviations. That's colorectal cancer. That's endometrial cancer. Your lifetime risk by the age of 70 is what the statistics have of developing colorectal cancer is 80%. 80% chance if you have one of these genes, you will get colon cancer in your lifetime. 60% chance that you will get endometrial cancer by age 70. Endometrial cancer is a distinctly rare, unlike colon cancer, endometrial cancer is a rare cancer in the general population. It's not rare, and it is preventable in the Lynch population. So that's very important. Here on the bottom of this slide, I listed the other cancers that are associated with Lynch syndrome, or HNPCC. And you can see there's a whole host of them: renal, biliary, small bowel, pancreas, brain, sebaceous adenoma. The 2 I think are most important to keep in mind are gastric and ovarian. So we talked a little about ovarian, and if you have a Lynch syndrome, a Lynch mutation, and you're female, you have a 13% lifetime risk of developing ovarian cancer, which normally in the population is a 1 to 2% risk. So that's very significant. And you have a 12% risk of developing gastric or stomach cancer. So if you're thinking about your family history and you just ask, listen, did anyone have colon cancer, uterine, which is endometrial, ovarian, or gastric? You will pick up the vast majority of families that have Lynch mutations and Lynch syndrome because of this high penetrance. So that's, I think, you know, something that everyone can do. And, you know, I'll show you the risk of second cancers in a subsequent slide. But again, if you get a cancer, now you can hope to survive it. And we're making huge inroads in most cancers, but certainly with colorectal, we've made enormous inroads. So if you get a colorectal cancer, you take care of it, you treat it, and then you immediately turn your attention to why and what you can do to prevent and protect yourself and your family from other cancers. Okay, remember I said we tend to divide the hereditary colorectal syndromes into polyposis and non-polyposis. Those were the non-polyposis. The polyposis syndromes, these slides are like when I go to the literature and I look at the studies. What if you have a familial FAP, familial adenomatous polyposis syndrome in your family, or AFAP is attenuated familial adenomatous polyposis syndrome? What is the chance, looking at each study in the literature, that that family or that patient will develop colorectal cancer? Every study in the literature shows these results. If you have familial adenomatous polyposis or attenuated FAP, you have certainly greater than an 80% chance. And most studies are about a 90, 95, 100% chance of developing colorectal cancer. Those can be prevented. Those cancers can be prevented if we pick up the fact that you're at risk before you get it. There are other genes that I was talking about that we're learning about, and the MUTYH, or the MAP-associated polyposis, that's the only one that I'm talking about that is actually an autosomal recessive inheritance pattern. So in that, where the presentation is somewhere in between the polyposis and the non-polyposis. So in the polyposis, remember I told you, the carpeted, the polyps they're too many to count. The gastroenterologist just sees a floor of polyps. In the non-polyposis, like Lynch, you may only have 5 or 10 polyps, and that still gives you this high risk of colorectal cancer. The MUTYH is right in the middle of those two. You can have 20, 30 polyps, but it's also autosomal recessive. So that's the only one where you may have 0 family history of any cancers and still have that mutation. I would say this, though, you don't ever assume if there is a cancer that just because there's no family history, there's no mutation. Because just remember, it's a lot for an embryo to form and to be born, and mutations occur. All these mutations had to take place sometime in the past, so they can occur anytime a child is born. So you can be the first one in the family to carry a mutation. So that's where you look at those things I was talking about before, about unusual patterns of expression, like a very young age or a second cancer. This is what I wanted to say about secondary prevention. And this is why I'm so anxious for people and the population at large, and for doctors to understand the hereditary basis of colorectal cancer. Because if you get a colon cancer from Lynch syndrome, you have a very high chance of developing a second Lynch-associated cancer. So you can see you have a 30% chance, if you've gotten one Lynch cancer, of developing another Lynch-associated cancer within 10 years of that first diagnosis, and you have a 50% chance of getting a second Lynch-associated cancer after that first cancer has been diagnosed. Those are cancers that we absolutely can hope to protect you from and change survival, intervene in a meaningful way to affect your survival. I put the risk of second cancers with the familial polyposis, familial adenomatous polyposis syndromes on the bottom. Those are relatively low risks. They exist, the second cancer risk exists, but I think the most important thing to know, if you find that there's a familial adenomatous polyposis gene in the family, is that those people need to be told that when they have children, they have to inform the pediatrician, because those children have, for the first 5 years of their life, an increased risk of a hepatoblastoma. So they have to have surveillance for the first 5 years of their life. The pediatrician must know about this, so they're watched with serial liver imaging and liver function tests. This is just something that didn't come out, but it's supposed to, you can probably guess, it's supposed to show you the risk of second cancers and of endometrial cancer. Okay, so now I wanted to just talk about, you know, so that's what you all can bring to the table for us in helping us understand whether there is an increased risk of a hereditary colorectal cancer in the family. From our side, the doctor's side, these are the kind of things we need to assess and look at to try to understand what's going on. So we ask, that's why I say, go talk to your family before you even show up. And then if you don't get the information, and nobody gets all the information. Most people are very foggy on this. A lot of people didn't even talk about what kind of things were going on in their family. That's okay. Whatever you know is helpful. So as much as you can get, and we try to draw expanded pedigrees, we try to understand that we'll ask, what kind of cancer did your relative have? So how is that person related to you? You know, was it a first degree, second degree, third degree relative? So you'll describe, well, that was my grandmother's sister, you know, and we want to know what kind of cancer. We want to know, was there a history of polyps, colon polyps in the family? If so, what age were those polyps diagnosed? And then we try, where we can, to get some confirmation of the pathology of the polyps, because not all polyps are equal. They don't all behave the same. You know, the gastroenterologist, when you go for a colonoscopy, takes out every polyp that she or he sees, right? There are some, the reason they have to take them all out is not because they could all turn into cancer. Some would never turn into cancer if they were left, but you can't tell which are which until you look at them under a microscope. So they have to take out all of them. So we would like to know, okay, what was the histology, the cell type, if we can get it, of the polyps that were removed? Then we need a detailed medical and surgical history. So that's where, of course, we're going to ask about your own personal history of cancer. And we're going to be particularly interested in associated cancers with genes for colorectal cancer. But we're going to ask about your previous colon history, including your history of polyps and the age, and then past medical illnesses and carcinogen exposure. And then we focus our physical exam on those things that I was pointing out to you can exist with the polyposis and the non-polyposis. So when I'm seeing a patient, I'm very interested in their skin exam, because if they have, and this has happened many times, dermatologists who are on the ball will pick up a sebaceous adenoma in a patient, and that's how we diagnose a Lynch patient, and then we intervene before they get any cancers. So those are very helpful, very important for us. Then our job as your doctor is to try to assess your risks, to counsel you, to educate you about what risk is, to counsel you about how to manage it. And that is obviously a complicated and in-depth process. And it's not the same for everyone. You know, you have to listen to what the patient is saying and what they are focused on and what they are looking for. And you have to tailor your message, but get the information across so that everyone can understand what the hereditary basis of cancer means for them and how it can help them. In some cases, it will be appropriate to do genetic testing. And in those cases, it's extremely important to make sure that the genetic testing is done with somebody who can help you understand what the implications of that testing are. Because it's not like a blood test, you're anemic or you're not anemic, or like a pregnancy test. Yes, no, it's not like that. You're going to get different answers back looking at those genes, and the person you're speaking to who's counseling you has to be able to interpret what those genes are showing and explain the limitations of what those gene tests show. Because just because you get a negative, you can send every gene that's known under the sun right now, and this happens plenty. Say, you know, you get, and every gene, negative, negative. The lab comes back, no mutation, no mutation. Yet you look at that family, and you know for sure that there is some genetic hereditary cancer syndrome in that family. It doesn't mean the person in front of you who doesn't have cancer has it, but it means that we haven't discovered it because it's in the family and the gene tests are saying it's negative. So it's very important to then turn to what the risk models show and what you, together with your doctor, decide is the appropriate screening and surveillance and prevention. So this is from our society. The NCCN is the major clinical guidelines that are used by oncologists. This is the society guidelines. This is what NCCN says to do if your patient has, this is Lynch syndrome. You should start, now this has gotten sort of modified a little bit as we've understood more and more the specifics of each Lynch of those 5 mutations. But in general, you can see that if you have Lynch mutation, you have to start colonoscopies at the age of 20 to 25 and do them every 1 to 2 years and every single year after the age of 40. And I can't stress how important that is. These colon polyps that form with mismatch repair mutations, the genes that are altered, and in Lynch syndrome, those polyps grow at a completely different rate than normal colon polyps. And you cannot wait 3 years or 5 years in between colonoscopies, because then the patient will have cancer that could have been seen earlier as a polyp and prevented. And then NCCN guidelines for Lynch patients is that they should have endometrial, uterine endometrial aspiration, transvaginal ultrasounds, and a blood test called a CA-125 as well, starting age of 25, every 1 to 2 years. Now, the NCCN guidelines for the familial polyposis syndromes, remember, those are the ones where there are innumerable polyps, and the literature shows basically greater than 99% chance of getting colorectal cancer. And in their lifetime, those people have to start, because of the predilection for familial adenomatous polyposis, it has a predilection for the rectum. Those children have to start sigmoidoscopies at age 10 to 12. And then anyone with polyposis syndromes have to start colonoscopies every 1 to 3 years, beginning in their late teens or early 20s, and should have upper studies of the endoscopy in the stomach and duodenum at the same time. Then the management, which I'm not going to go into because I think you're going to have a very nice talk on it with Dr. Raff, but the management of colorectal cancer risk is surgical prevention, meaning a total colectomy to prevent it, or enhanced surveillance, meaning colonoscopies, endoscopies, and imaging. And we are working on very actively on chemoprevention. I put up the only things that seem to have shown any real data, and there seems to be some data that aspirins, nonsteroidal anti-inflammatories, and oral contraceptive drugs can reduce the risk of colorectal cancer. But I certainly wouldn't rely on that, and we need more effective agents as well. And then obviously, I think it's very important to consider your lifestyle and try to modify the things that you can modify, because there's no question that as a group, this is a relative risk factor, but as a group, relatively, it will reduce your risk of colorectal cancer. And my last slide is to tell you to just get in there, make sure you think about these things, plan, talk, get a doctor who you can talk to and work with. Work as a team with your doctor. Don't be afraid to advocate for yourself. And don't think that anything you've done in the past can't be altered. You can, and get your colonoscopies. Okay, thank you.
That was fantastic. I just wanted to mention that Yeah, I don't want to keep you here if you want to.
No, that's okay.
If
You
you
want me
feel,
to go over there?
if you feel safer over there.
No,
That's
I'm fine exposed, take your pot shots.
The thing is, Dr. Smith, that many of our survivors spoke to us about the fact that, they were diagnosed with advanced disease at age 36. They saw their providers. No one spoke to them no one even asked them about their family history, let alone directed them to appropriate genetic referrals. So I think, one question would be, especially for someone like yourself, who is a national, international leader in the field, are there steps you see that we might be able to take to really lift the bar a little bit in terms of what providers understand about what they need to do? It's for people of our generation with our passion for genetics and cancer, it's a quote-unquote no-brainer, but it's definitely not happening out there. Do you have any comments on that?
Yeah, I have a lot of comments on that, but I'll try to confine myself to a couple. Look, this is, the field of genetics and cancer and prevention, as I was saying, it's a new field. I've never seen a field in medicine change as rapidly as I've seen this field change. And people are getting the idea. And the way the people get this idea is by all of you, not just us. We will work hard to get the providers, your doctors, aware to bring them in to an understanding, and we are working hard, and it's getting there. But this is the way the field changes. It changes, I believe, by a true grassroots effort by people who understand there is something going on. I think that, I'll just say one more thing about this. Look, what happened with AIDS? This was the model for all cancer evolution. There was pressure, tremendous pressure from the AIDS patient and family community. It didn't come from NIH. It didn't come from the academic institutions or the doctors who were practicing. Everyone was very upset. But the pressure came from an enormous outswell and grassroots effort. That became the model. That's changed. We lived through the AIDS epidemic, and the difference now is enormous. So that's how it has to work. That same model was then taken up by the breast cancer group, and it made huge advances. That's how it has to work, I believe.
Great.